Welcome to the Clinical Cousin YouTube channel. This video is on heparin-induced thrombocytopenia, also known by the acronym HIT, also known by the name white clot syndrome. So what is heparin-induced thrombocytopenia? Well, it's in the name. It's a low platelet count caused by the patient being on heparin. What patients are we putting on heparin? Patients who have clots, maybe a PE, DVT, maybe they're having a non-STEMI MI, maybe they're having an MI, and it's going to take a little bit for cardiology to get there because it's the weekend. So let's first discuss thrombocytopenia so we can understand what it means within the name of HIT. And a thrombocytopenia is technically a platelet count less than 150,000. However, clinically, it's really not significant until we get to platelet counts less than 50,000. That's why you're not going to see your provider move much until we get here. Now at levels of around 30,000, we can get spontaneous bleeding. Around 20,000, we can get severe bleeding. Around 10,000, they may start to think about prophylactically giving platelets. And at levels of less than 5,000, we can have extremely severe bleeding. We also need to remember before major surgeries, we usually need a platelet count around equal to or greater than 50,000. Now, in heparin-induced thrombocytopenia, the one thing we're going to find is that these numbers are sort of misleading because we can have platelet counts of 60,000, but they're bleeding severely like they have a platelet count of 20,000. However, the main problem with HIT is not bleeding, it is thrombosis. Thrombosis worse than bleeding. So how do we get to that clot formation? We'll discuss that in just a minute. Other thing we need to remember is we're dealing with platelets, so those are primary hemostasis pathways, not our clotting factors, which is what heparin works on. But these platelets are involved in primary hemostasis. So what are the signs and symptoms physically we would look for people with low platelet counts? One's increased bleeding times, PTINRs, PTTs, those aren't affected. However, we have superficial bleeding, bleeding from mucosa. We may see gingival bleeding, but our secondary hemostasis with our clotting factors, that's one where we see wounds reopen back up and we see bleeding from there. Deep bleeding, hemarthrosis, bleeding in the joints. So platelets, we're looking for petechia, purpura, ecchymosis, those things, bleeding around the gum line, etc. So now that we know a little bit about thrombocytopenia, so we can understand what's going on here, let's start to look at what causes a clot. Why do we need to put the patient on heparin in the first place? We'll take a look at Virchow's triad. Some people call it Virchow's triad. It's Russian, so I think it's supposed to be called Virchow's. It's not as important. What's important is that you understand what's going on. This triad is three things that lead to clot formation. One's endothelial damage, so that endothelial cells, those thin, flat squamous cells that are cellularly lined throughout the circulatory system, when they're damaged or separate, they will start some of these coagulation pathways that form a clot. To form when a clot forms, they can get bigger and form bigger clots. Bigger clots can start blocking circulations to areas like pulmonary circulation. They can cause those legs to swell up and give that appearance that patients come in saying, my leg's swollen, I've been on a long trip, and we know it's a DVT. So that's one mechanism that can cause it. The other one's hypercoagulability. So maybe we have someone that likes to smoke a lot, their body's in a steady state of low-grade hypoxia, and because that, it stimulates erythropoietin to be released. That erythropoietin makes them make more red blood cells, their hematocrit level increases, and we call this secondary polycythemia vera. Increased risk of clots. Maybe they're on estrogen and birth control. Increased risk of clots as they make more red blood cells. Maybe they have lupus anticoagulant, which is a misnomer. It should be named lupus hypercoagulant because it causes clots. All those can contribute to clot formation. The other thing being stasis, we've got a patient who has been out on the road, taking a long road trip. Their knees have been bent, that venous flow's been obstructed, and now that blood's settled there and it's formed a clot. That's a big cause of DVTs. So we may have people after long flights or after long road trips coming in or after sitting with their legs bent in the office for a long period of times come in complaining of one leg swollen more than the other, and their wonderful husband or their wonderful wife has massaged the leg and now they're becoming short of breath and they feel their heart's running away from them because they probably let loose that thrombus and now it is in their lungs causing a PE. So these are all the reasons our provider may put our patient on a heparin drip. If it's not bad enough to require intervention, they're going to go on a heparin drip. Also, maybe we have an MI, maybe the ST elevation's not there, but the troponins are increased, or maybe it's just not significant enough for the cardiologist to come in because it's the weekend. And we all know they get together on the weekends with their friends, practice interventions and study together so they'll be better equipped for Monday through Friday, 8 to 5:30. But our patient's having a slight MI, so what does the cardiologist say? Put them on a heparin drip, trim the troponins. That's another reason we may be on a heparin drip. That's great. Unfractionated heparin is a wonderful thing. It starts working almost immediately. It keeps the clot from enlarging. It allows our body's natural TPA to start lysing those clots up, breaking them up, and to do what our clotting system does. However, in 2 to 4% of those patients, we are liable to end up in a state of thrombocytopenia. Why is that bad and how does it happen? Well, case one, your patient's fine. You look at your patient, he's fine. You draw morning labs, you draw evening labs, you're drawing every 6-hour labs because they're on a heparin drip, or maybe daily because you've got them locked in and their levels are staying fine on their PTTs, and you notice that their platelet count is precipitously low, but your patient's fine. This is the first case we're talking about. This is going to be HIT type 1 non-immune. You call your doctor up or provider, and you say, hey, my patient's platelet count is suddenly dropped. I don't know what's going on. The doctor says, stop the heparin, start argatroban or loperidine, start argatroban. That's going to be on CCRN. And you're going to say, why? He's also probably going to say, or she's going to say, let's get a peripheral smear. We want to make sure the EDTA in the purple top's not causing the cells to clump into these satellites, which will make the machine misread and read maybe 8 platelets as only 1, and therefore you could have a pseudo-thrombocytopenia. But you get that back, and sure enough, the patient is thrombocytopenic. Their platelet count's low. So you go, crap, and you started argatroban, and you're like, I don't know what happened. But I know that the provider's done the right thing. He stopped it, and I've heard about this condition called HIT. So I know I'm doing the right thing. The next case is the scary one. This is going to be the type 2 case. You go into your patient's room, you're getting ready to draw labs, and you notice they're super tacky, they're short of breath, you're putting them on oxygen, they're not getting better. They had a blood clot in their leg's twice the size it was before, but they're on a heparin drip. You're thinking, the clot's obviously got bigger, and I think it's thrown and it's went to the patient's lungs. They may have a PE. So you rush to the phone, or you call your buddy to go to the phone. We need to get a provider in here immediately. The provider comes in, he says, stop the heparin. Let's get this patient sent for a PE scan. Start the argatroban. Now, what's different about this patient as compared to the other patient? Well, this patient most likely has HIT type 2. So now your patient's got precipitately worse. This is bad. HIT type 2 has a 20% mortality rate. That means 1 in 5 patients who go into HIT type 2 will not survive. Why and what happened to cause this thrombocyte count, platelet count to drop, and why are they developing worsening clots? They're on heparin. I don't understand. Here's what happened. First off, when a patient's put on heparin, heparin is naturally found in the body, but we're given in excessive amounts that are normally not found there. Now, what happens with the platelet? Inside the platelet, there's something called cytoplasm in the cell. Inside the cytoplasm, there's things called granules. In these granules, there's alpha granules that contain platelet factor 4, and there's dense granules that contain serotonin. We need these for platelet aggregation and clot formation. So heparin decides, or platelet factor 4 decides, it wants to join up with platelet factor 4. So we get a heparin platelet factor 4 complex. Now this looks extremely strange to your body, and just like with a bacteria or a virus or anything else that's foreign to your body says, hey, I'm going to show this to the immune system. I'm going to find a B cell matches up with this. We're going to split into a plasma B cell, a memory B cell, and we're going to start pumping out antibodies to fight this, because this shouldn't be there. Unfortunately, it should be there. We're using it to try to get rid of this clot. So the body starts making antibodies, and we know with vaccines or anything, significant or clinically significant antibody production takes around 5 to 10 days to get enough antibodies developed or produced in order to fight off whatever the infection is. Well, in this case, it's fighting those platelet cells that have platelet factor 4 in them. So what happens when that immunoglobulin G or IgG or that antibody comes and fights that complex? Well, it causes your platelets to go crazy. they start releasing serotonin, they start linking up through their glycoprotein 2B3A receptor sites, which also link up with fibrinogen, which also link up with von Willebrand factor, and we get huge clumps of platelets, which are clots, and huge clumps of fibrin, which are clot formation, and our clots get worse and our patient gets clinically worse. And because we're using or clumping all these platelets together, we have less platelets floating around in our bloodstream, so we end up in thrombocytopenia. So what do? The platelet count's super low. Let's give them more platelets. Wrong. Unless there's severe hemorrhage, major hemorrhage leading that would lead to death, otherwise they're not going to give platelets. Why? If I give platelets, they're going to be attacked by these antibodies. These antibodies are going to cause those platelets to go crazy. Those platelets are going to clump up. Clots are going to get worse. Patient's going to die, and you're going to be in litigation with your physician or provider. So what do? We stop heparin. We start argatroban. That's our answer. Why argatroban? Argatroban doesn't work on those heparin pathways. It's not a heparin. In fact, it's a 2-activated or 2A or clotting factor 2 inhibitor or thrombin inhibitor. All mean the same thing. So thrombin causes fibrinogen to turn into fibrin, and those form clots. So we're going to stop it right there on the pathway. We do it or loperamide. Now, we may say, why not give Lovenox? Sounds like a great idea, but Lovenox is a low molecular weight heparin. Heparin, PF4 complex, we don't want those. Less chance of forming, but still could. Synthetic heparins, no, the word heparin's in it again. Let's not try that, although that even has a less chance of hit formation. Okay, so we bring up to our provider, well, why don't we give the patient Coumadin? We can start them on oral Coumadin, right? Well, we got a few problems with that. Coumadin takes a long time to work. By the time it works, your patient's clots, they filled up with clots, they're dead, their platelet counts drop, they're bleeding out. They're dead. The other thing is Coumadin, when you first get it, actually causes clot formation. The reason it does this, it works on the extrinsic pathway. It helps inhibit clotting factors 10, 9, 7, and 2, which is great because that slows down clot formation. But unfortunately, before it inhibits those, it inhibits protein C and protein S, which are actually anticoagulants. They put the brakes on coagulation. They slow it down so it doesn't clot so fast. So if I put the brakes on the thing that's causing clots to form and to slow it down from the clots forming faster, my patient gets worse faster, their thrombosis grows and they die. That's why we leave them on heparin until we bridge them over and patients' PT-INRs elevate enough and they've been on Coumadin long enough that it no longer just affects protein C and protein S, it affects clotting factors 10, 9, 7, and 2, and it becomes an anticoagulant. So we don't give Coumadin. Other thing with low platelet counts, Coumadin can leave, and you can Google this. Coumadin or warfarin can lead to warfarin-induced skin necrosis. So we don't want that either. So that's HIT type 2. When are we going to expect it? 5 to 10 days after they've been on the heparin drip, unless they've had previous exposure to heparin. Same as if the first time you get in poison ivy, you don't break out. Second time you get in it, you break out bad because now your immune system's primed. Same thing. Maybe they came in, got a few shots of heparin before a year ago, and they were fine. Now they come in, you have them on a heparin drip, and the very same day you put them on them, you notice they get precipitately worse when the drip started. Think about HIT type 2. Stop the heparin, start argatroban or loperamide. Remember, argatroban, tro, like thrombin, ban, to inhibit. Thrombin inhibitor. That's a thrombin inhibitor or 2A inhibitor is a good way to memorize that one. That's going to be your pathway. How are they going to test for HIT? Well, after you've removed that, they may order an ELISA test, which is a test to see if the immune system's been primed up, and it'll be an ELISA test against PF4, platelet factor 4. Great test. Unfortunately, like D-dimers, it's extremely sensitive, but not very specific. So like if your D-dimer's elevated, you think, oh, they got to have a PE. No, they don't. And everyone hates to hear that. It means that I need to investigate further. If a D-dimer is negative, I know that there's about 0% chance they have a clot because there's no fibrin degradation products from a clot being broken down. However, if it's positive, they could have had surgery. They could be having an infection. Anything can be going on to elevate that D-dimer. for every decade of life, it'll start elevating. So there's a lot of reasons that a D-dimer can be elevated that don't have anything to do with PE. And same way with this ELISA against PF4, there's reasons it could be elevated. Other than that, the only thing this tells me is if it's negative, I don't have this. But if it's positive, I need to further investigate. So they're probably going to send a serotonin activity test out too. Serotonin activity being increased, say as platelets have been activated and went crazy, this tells me I most likely have hit in the picture of thrombocytopenia. These two being positive and my patient get precipitously worse after heparin was started in the timing of around maybe 5 to 10 days or day one if they've been previously exposed to heparin. So that's what you need to know for the CCRN exam. Remember this, if you remember nothing else: low platelet count, patients getting worse, they're on heparin. Stop the heparin, start argatroban. This is our video on heparin-induced thrombocytopenia.